actually why this concept is necessary, where is this concept necessary, and how to do it. These are the three basic areas I am going to highlight. See, first of all, the left ventricular ejection fraction is the commonly utilized echocardiographic parameter to evaluate the left ventricular systolic function that we know. And it is being used for the last 1.5, almost more than that, monitoring of therapy, choice of different therapeutic intervention, and as the most powerful prognostic indicator for risk stratification in various cardiovascular diseases. However, LVF is a coarse measure of global LV function with various limitations. What are those? Reliability of LVL for the assessment of LV function has been questioned for the last 1.5 decade because there is a late reduction of LVF only in advanced stage of the disease. There is geometric assumption for calculation of the LVF. It's load dependence. There are a lot of inter-observer and intra-observer variability. And of course, certain cases, difficult endocardial border delineation. As we all know, the left ventricular muscle fiber organized in complex layers. The subendocardial layer oriented counterclockwise and the subepicardial oriented clockwise fibers arranged longitudinally forming a loop around the ventricle. And the mid-myocardial fibers are laid out in a circumferential manner. So there is a complex interplay of deformation of the LV myocardium in systole and the diastole is found during contraction and relaxation of all these different type of muscle fibers. Hence, any early changes of global and regional preference of LV systolic function may not be reflected by estimation of the LVM, which may remain normal during the initial phase of any cardiovascular disease. But echocardiographic strain imaging can evaluate both regional and the global myocardial function, longitudinal, radial, or circumferential contraction of the left ventricle can be quantified by the strain imaging. So evaluation of the LV systolic function by strain imaging, mainly the global longitudinal strain, which we call GLS, is frequently used in regular clinical practice as has been incorporated into major guidelines. Remember the major guidelines. GLS is considered as accurate as solo micrometry and MRI in most cases and predicting mortality in various clinical conditions. Its utility in detecting the early subclinical LV dysfunction, specific regional variation in different cardiomyopathies, monitoring therapy, and to prognosticate in various conditions has led to its increasing use in regular clinical practice. So a little overview of the strain. What is strain? Strain is nothing but the deformation. What is deformation? That deformation resulting from any applied force. So besides physics, the magnitude of a deformation equal to the change in the dimension of a deformed object divided by original dimension. As for example, we start in the L0. If it is lengthened, then it becomes L1. So strain is L minus L0 divided by L0. That is the change of deformation. So I'll give you an example. Say L0 is 1 centimeter, L is 2 centimeter. This strain is equal to 2 minus 1 by 1, that is 100%. But if it remains same, then 1 minus 1 by divided by 1 is 0, that means 0 strain. So it may be 0 to 100. Now, this is the calculation, the formula I have already told you, that is the L1 by L0 by L0 into 100. So that strain can be positive. Suppose there is a lengthening. So suppose in this issue is a 5 centimeter initial, then 8 centimeter. So 8 minus 5 into 100 plus 5. So strain is plus 60%. On the contrary, if its initial length was 8 centimeter and the lateral length was 6 centimeter, so it will be 6 minus 8 by 80 into 100, so minus 25%. But there is a difference between the strain and the strain rate. See, both the cases, the strain is the same, but strain cannot tell you how long the deformation takes, how much time it takes. It can take even 1 millisecond, it can take even 1 year. By that, if you divide it by the time, it will give that strain rate. So far, there are various methods, but two important methods I like to discuss is one is the tissue Doppler imaging and the 2D speckle tracking. That is the HD are two important echocardiography modalities are currently used to quantify strain. But there are certain drawbacks in the TDI. What are those? TDI is Doppler derived strain by the spatial derivation from the velocity data. and subsequently temporal integration of the strain rate will calculate the strain value. However, the major limitation of the TDI strain is angle dependency. So these are the TDI strain and this is the speckle tracking strain. And what is this? So TDI strain can estimate the longitudinal strain, while radial strain is derived from certain regional segment, where manual tracking of the sample is necessary for a particular myocardial segment throughout the cardiac cycle to avoid noise from blood pool and reverberation on the 2D echocardiography image. And of course, in the TDIs, higher frame rate is required to avoid the undersampling. In contrast, 2D speckle tracking tracks the ultrasonic speckles within the myocardium and can be traced from routine 2D echo images. Offline, single speckles are called kernels, which merge into functional units. As a result, an ultrasound fingerprint is produced from each kernel, which can be tracked by inbuilt software. And the ST can be affected by afterload, but it is angle independent. That is very, very important, and the less intra-observer and inter-observer variability and taking minimum time than TDI strain. So this is a major difference between the TDI and this. The most important, the speckle dependency of the imaging quality is very high. There is a 3D acquisition is possible, rotational mechanical analysis is possible, and of course you can differentiate all the type of strain in the speckle tracking. So here is the speckle, and this speckle identifies specific pattern called template. And if you go by frame from this frame to this frame, this frame to this frame, search the place ultrasound beam where the templates move. And as a result, you can get the strain value from the movement of the template. But one thing must be clear in the mind. There is always a tethering in case of, but tethering is not the strain. Strain and strain rate are not affected by tethering. Whereas the velocity we measure in the TDI, the velocity that is the E prime or the S prime or the displacement affected by tethering. So it's a better choice. There are four principal types of strain and the deformation. One is longitudinal, radial, circumferential, and of course the rotational and the torsional strain. So these are mainly the basal part is clockwise rotation, apical part is counterclockwise rotation. This is the longitudinal rotation, this is the radial thickening, and this is the circumferential thickening. So here is the longitudinal, you can see there is a shortening, so it will come as the negative strain in systole. In the radial, again there is a thickening, so there will be positive strain. And in circumferential, there will be again a shortening, so this will come as a negative strain. So ST can estimate LV strain in all planes, circumferential, radial and longitudinal. And only more than 60 frames per second is required to analyze offline. What do we do usually? Endocardium is manually traced and the software automatically divides each apical view, that is the apical 4 chamber, 2 chamber and long axis view into 6 segments and analyze the total 18 segments. The tracking quality for each segment is evaluated and if necessary manually corrected, and then software generated the strain curve. Remember, if 2 or more segments of any particular apical view are poor tracking quality, strain evaluation should not be done. And what you will get, the two important things. One is the bullseye representation and the strain rate curves. Both are important. I'll tell whenever I go to the specific cases. So how to do it? First you take, suppose is the apical long axis view. This is the apical long axis view and here is the apical long axis view. So you put the apical long axis view into mode and automatically your endocardium is traced. If you find is not tracking the endocardium properly, you can, by this point, you can manually trace it to that so that you can go into the endocardium very clearly. Once you are satisfied, then put it, then you will get this type of picture where you can find the endocardium is totally delineated by this thing. And you will get all the 6 segments of a particular view, they will give it's okay. When it is okay and you are satisfied, then put approve. When you put approve, you will give this quad type of format. What are the quad type of format? What are the 4 things you will get? These are the things. First is the color coded RY. So where you can see the movement of the total 6 segments together. Then what is this? This is the peak segmental strain of each segment. They will be mapped in this area. What are the third? Third is the segmental or the regional strain curves. where if you put the cursor here, you will get the particular segment to see here. And you can see another important thing is that whether all these segments are peaking before the aortic valve closure. That is very, very important upcoming thing. And last is you can even see in the curved anatomical color of bone. So this is actually the quad format. So this way, first the apical long axis view, then you can use the 4-chamber view, same thing, and then you will the 2-chamber view. Once you finish these 3 views, the basin automatically gives you this format. So this is the 4-chamber view, this is the two-chamber apical long axis view, and this is the 2-chamber view. And these will give you ultimately the bullseye map, where you can represent all the 3 views, the average strain and total average strain of the left ventricle. So this is the total average strain of the individual views, and so here it is near about coming to 23.8%, which is regarded as a normal. And what the bullseye actually represents is that peak systolic strain. You can get the peak systolic strain from here. The blue is positive and the red is negative. So all the maximum negative means better strain. Blue means lighter strain, but lower strain, I think. So peak systolic strain this way. So this bull map is finally generated automatically by software analysis in 3 apical view. I'll only concentrate on the mainly longitudinal strain. Why, I'll tell you. But a brief, I'll speak about the radial strain. What its normal value is near about 40 to 60, plus 40 to 60% is estimated by deformation of the myocardial fiber, which are directed towards the center of the left ventricle and recorded as a positive curve as myocardium thickens during systole. Which view is necessary? LV parasternal short axis view at the level of the papillary muscle is done for the estimation of the radial strain. I'm not going into the detail of this. Another is the circumferential strain, which is near normal. Its value is minus 20%. Is performed at the LV parasternal again short axis view at the mid level, and strain is recorded as a negative curve by shortening of the myocardial fiber along the circular left ventricular perimeter. So why the longitudinal strain is important? Because the longitudinal fibers, subendocardial fibers, are mainly involving the longitudinal fibers, and that's why longitudinal strain. Whereas the mid-myocardial and subendocardial fibers are responsible for the circumferential and the radial strain and the rotation. And the most of the cardiac pathologies involve the subendocardial layers first. So longitudinal strain is usually the earliest to get compromised. Whereas radial and circumferential strain remain preserved or even may be accentuated during the early stage to compensate for the loss of longitudinal strain. Actually, conceptually, what you find, the longitudinal strain is the robust, and it is being supported by the circumferential and the radial strain to maintain the ejection fraction, which is happening normally. But when there is a preserve but decreased GLS, you see the longitudinal strain becomes reduced. As a result, radial and the circumferential strain rather increase to maintain the ejection fraction. So, earliest to find out is the longitudinal strain. And as the disease becomes more extensive and more transmodal, the radial circumferential strain also get progressively impaired. Conditions that affect the heart from the outside, another important is that anything not involving the myocardium, anything involved with the outside, like constrictive pericarditis, where is circumferential and rotation may get compromised earlier than the longitudinal strain, which is usually preserved. Another important concept you have to understand is the post-systolic shortening. Segment continues shortening after the aortic valve closure, after a certain relaxation and giving 1 or 2 peaks at systolic and a post-systolic, a single peak after the AVC. See, a small amount of post-systolic shortening may be present in a normal person, in the 1/3 of the normal segment, but not more than 3%. Any pathological strain, we call it reduced systolic strain and higher post-systolic strain in magnitude, as well as the later PSS. So it is a very important area of the longer the persistence of the PSS, the post-systolic strain after an ischemic event was severe coronary obstruction. PSS is formed because of the inhomogeneity of the forced development due to the difference in activation, load or contractility, and not as a specific marker of ischemia. PSS at rest can be a sign of ischemia, myocardial scar, or any other condition. However, PSS which occurs during stress cardiomyopathy is always denotes ischemia. So it can improve the accuracy of detecting coronary artery disease during a dobutamine stress test. So how it looks like in a normal person is the PSS. This is the post-systolic. There is all a 0. See, that means there is no post-systolic strain in this. But if you see another one, there is an inferior or posterior myocardial infarction. You can see the lot of segments are peaking after this is the aortic valve closure, after the aortic valve closure. Here 1 or 2, here majority are peaking before the aortic valve closure. So certain are peaking above the aortic valve closure, or certain are peaking before the aortic valve closure. So if you see this bullseye map, you can see these are the area there is a no post-systolic strain, but this is the inferior posterior lateral area is there is a post-systolic strain. So what is the requirement for strain imaging? What is that needed? One is that you have a good important machine which has this software to evaluate. Second, you have to have an excellent 2D image. Without excellent 2D image, your values are get erroneous result. Third thing is that you get the very good quad format to evaluate your findings, and last a little bit of experience. So subclinical systolic dysfunction can be detected by GLS in spite of normal EA wave, and segmental LV function can also be quantified, and that is now coming in. Already global is recommended in the guidelines, but still segmental deformation is also coming in. Is a prognostic, there is a very interesting paper, there is what called the prognostic value of patient with the LVA more than 40% is absolutely limited. If it is less than 40%, well, we can predict. However, GLS can predict the prognosis even at this range. Hence, the prognostic value of GLS in heart failure patients are much more predictive than LVA. Whereas reduced GLS is associated with the mortality, but not so accurate with the LVA. And GLS can provide more information than LVA. But there are certain caveats we must remember. Most important is that there is these are the same image by GLS is determined by the two different vendors. The difference is one is 16%, one is 21%. So what to do is this. Here is the recommendation is that because of inter-vendor and inter-software variability, serial assessment of GLS in individual patients should be performed using the same vendor equipment and the same software. That is the caveat 2. There's a lot of controversy. What should be the normal value of the GLS in different machines, even in the same machines, in the different setup. So what is the now recommended at the moment? Recommended is that peak GLS in the range of -20% can be expected in a healthy person. And the lower the absolute value of strain is below this value, the more likely it is to be abnormal. So -20%. Caveat 3. I told you always the image quality. This is an image which is optimal for strain. And this is the image you can see, we're not able to see the endocardium, even the myocardium. This is a very suboptimal strain state. Where is the recommendation? Regional tracking is suboptimal in more than 2 myocardial segments in a single view. The calculation of GLS should be avoided. Last caveat is the caveat 4. I told you there must be some learning curve. This is a beautiful paper published here is in there by the fellow sonographer and the students. You can find out that at least 50 cases are required to maintain your balance of doing proper GLS estimation. So there is a significant learning curve associated with the LV strain analysis, and they are recommending is the minimum of 50 studies for training to achieve the competency of the GLS analysis. So now come to the clinical application. The clinical applications are many. It involves the left atrium, left ventricle, and even to the right ventricle. See, these are the charts I'm not going to enumerate because I'll be telling everything in the video in the next videos. But to simplify the clinical applications, there are 3 important areas we must remember. One is the pattern recognition we find in the bullseye phenomenon. Second is the subclinical myocardial dysfunction. That is the today's topic of discussion. And last is the upcoming subject is the regional variation. So I'll first going into the video, then how the normal GLS look like. Say, this is a normal person. Then no history of diabetic, not hypertensive, nothing, no history is there, is a normal individual. So you can see the good contractility from all the views. There is the 4th chamber view, This is the two chambers view, and this is the apical long axis view. And all the views are having the beautiful 2D image. And now if you evaluate this patient in the GLS, you'll find GLS near about 21%, and it is absolutely normal, and there is, these are the peak systolic strain, and there is a no post-systolic shortening, no, there is a post-systolic, so this is a normal patient. Now come to the pathologies. First is the valvular heart disease. Identification of the subclinical LV myocardial dysfunction is very, very important valvular heart disease, because impaired LAs is the first sign of myocardial dysfunction. We know the multidirectional strain and the strain rate impairment occur with increasing severity and the chronicity. Twist mechanism relatively preserved in the AS, AR, and the MR, including the peak systolic twist velocity, and the untwisting velocity. LS, CS, and RS improve after surgical intervention in AS. AR, initially there is a decline in the CS and RS, which improves over the next 3 to 6 months. I'll come individually. First is the aortic stenosis. Take a story of a 62-year-old male present with a dyspnea, chest pain, with a grade 4 to 6 ejection systolic murmur, and echocardiogram reveal lot of LV hypertrophy with a normal aortic stenosis with the mean pressure getting more than 60 mmHg and the LV of 62. You can see the good contractility with hypertrophic ventricle, and there is a thickened, calcified, almost not opening aortic valve, and same thing in the fourth chamber. You can see good contractility LV. So inpatient is totally asymptomatic. You can see there is a peak velocity is now reaching up to 6 meters, and the mean velocity is reaching near about 4 meters. And if you do this GLS in this patient, what you see, the GLS is only 16%. So whether we should wait for the EF to drop or no. See, severe aortic stenosis, the patient with the severe AS and the preserved LV, GLS is resolved mainly at the basal LV segment, which we saw in the last picture. Is the higher LV mass and the relative wall pixel lowered the GLS. If GLS is less than 70%, more than 70%, is the excellent 5-year event-free survival after the operation. We know GLS in low flow, low gradient AS provide better prognostic value during dobutamine stress echo when compared with the race. And the longitudinal function of the basal segment of the anterior wall, ventricular septum, are more affected because the amount of fibrosis and hypertrophy are maximum in this segment. So what is the recommendation? The patient with the asymptomatic severe aortic stenosis with GLS worse than less than -16, which is in our case. And other risk factor, of course we do it. There is high calcium core in the CT, or the myocardial fibrosis detected by MR may be considered for, or rather should be considered for intervention. Now comes to the aortic regurgitation. Here is a story of a 48-year-old male present with a fatigue, weakness, exertion, the sole and ankle and feet, light chest and pain, lightheadedness, heart murmur, and they say there is a severe aortic regurgitation. You can see in this picture is the case of severe aortic regurgitation. And in the next, you can pay by the pressure half time, but there's not much of gradient across the aortic valve. The pressure half time is less than 200, and so it is a severe aortic. But you can see the contractility of the left ventricle is well preserved. So we do the contractility is well preserved. So we did the GLS. Here is GLS again -17%. So what we should do in -70%? What is written in the literature? The patient with the symptomatic, moderate to severe aortic regurgitation have more impaired GLS than those without symptoms. Asymptomatic patient risk of death increases as GLS worsen beyond -19%. Our patient is already falling to 17%. So in need for aortic valve surgery in patient with the moderate to severe AR with preserved EF. And preoperative GLS worse than 19% was associated with the reduced long-term survival after surgical procedure. So you have to intervene before that. Now come to the mitral regurgitation. There is a story of a 32-year-old man, asymptomatic, pansystolic murmur, referred for echocardiography. You can see the severe MR. But contractility is absolutely fine. You can see the severe MR with absolute good contractility. See the GLS here? GLS is reaching up to 26%. So what will be the recommendation in the MR? See, GLS is 26.4%. Here is there are two catch. One is if there is a primary severe mitral MR and the asymptomatic patient was beneficial because all-cause mortality when GLS is worse than minus 21%. So preoperative GLS worse than minus 18.1 was predicted post-procedure LV dysfunction in patient undergoing mitral valve surgery. So anything less than minus 21, so our patient is 26, so we can wait a few days. So we can close by giving the closed follow-up. But if it is around 21% or around that, so you should go for intervention. But if it is a secondary EMR demonstrated GLS worse than minus 7% was associated with the increased risk for all-cause mortality, not the LVA. Secondary event, the story is different. After the valvular heart disease, now we'll go to the GLS differentiate LVH etiology. There are several causes of LVH, starting from athlete heart to hypertensive heart disease to hypertrophic cardiomyopathy to asymmetric hypertrophy to amyloidosis, everything. Where is the heart? What happens to the athlete's heart? GLS is not reduced in athlete heart. Why? Due to complex physiological adaptation of the long period of training. If a GLS you find in an athlete is reduced, then evaluate for other cause of myocardial dysfunction like coronary artery disease or the myocarditis, whatever it may be. We know the endurance athletes even have enhanced strength values. What happens to the hypertension? Our day-to-day practice. GLS is reduced in patient even without consenting remodeling or hypertrophy in hypertension. Initially, segmental alteration in the LS are found while the average GLS may remain normal. So you have to see the segment also. CS, RS and LV dorsal mechanisms are preserved and GLS can detect early subclinical dysfunction in new hypertensive patients without any LV hypertrophy. And improved GLS is found even after the beta blocker therapy. Here is a patient, you can see. This is a patient, newly detected hypertensive patient. Absolutely, there is no hypertrophy, good contractility. But you can see the GLS is near about minus 18.8%. So GLS started reducing. So these are the subset of patients need close follow-up. You have to find out the other metabolic syndrome is there is not known. You have to find out whether we can give the statin or the beta blocker, particularly in this type of patient. Then what happens when ultimately the patient develops the gross LVH even with the hypertension, but not the hypertrophic cardiomyopathy? Here is the story of a 55-year gentleman is not properly controlled hypertension. They presented with a lot of symptoms and echocardiography you will find. There is a gross LV hypertrophy, but the LV is hypercontractile, rather LVEF is preserved. And you can find out this is a gross LV hypertrophy, no intracavitary or LVOT gradient across the LV. And you can see here is the GLS is grossly reduced near about minus 12%. So even uncontrolled hypertension, there is a lot of fibrosis, there is a lot of hypertrophy, you will get the GLS is reduced. So these are the patients may develop heart failure very early. Now come the hypertrophic cardiomyopathy. GLS is reduced even in the initial stage of hypertrophic cardiomyopathy, but LVF is preserved. GLS correlates well with convexity of the septum, magnitude of the myocyte disarray, severity of the hypertrophy, and interstitial fibrosis. And GLS are more compromised at the site of hypertrophy. And not only that, GLS can predict adverse cardiac event like VT. I'll show in later. GLS is reduced more in HCM than in hypertension. And GLS can be used for risk stratification. If the GLS is less than 15%, is associated with the more than 15% is rather better survival. If it is less than 50%, that is in our patient is a worse prognosis. So I'll give an example of the HOCM. There's a 48-year-old man present with a shortness of breath, chest pain, history of panting, then fluttering heartbeats, then heart murmur. See, there is a gross hypertrophic septum. Also, the posterior wall is also hypertrophy, and you can see the cavity is almost obliterating, and where is a gradient across the LVOT and the mid cavity, and there is a gradient reaching up to the 4 meters. That means up to 65 millimeter of mercury at rest. And if you see the GLS in this patient is absolutely 4%. So that can happen in hypertrophic cardiomyopathy much earlier than hypertension due to the LVH due to hypertension. Another is asymmetrical septal hypertrophy. The same thing you can say, this is the case of, see the septum is hypertrophy, the posterior wall is absolutely normal. So you can see the septum is hypertrophic and posterior other walls are relatively normal. No intercavitary gradient, but you can see that starting from the base to the apex, whole of the anteroseptal earlier GLS is grossly reduced, and overall GLS is minus 7.8%, but here it is only 3 to 4%. Now is another thickened myocardium, but not the hypertrophic myopathy, not the hypertensive heart disease. Here is cardiac amyloidosis. Here is GLS is reduced in mainly the mid and the basal segment of the LV with the preservation of the apical septum. We know the apical septal to basal septal GLS ratio is more than 2.1, differentiated amyloidosis from other cause of the LV hypertrophy. Whereas in Fabry's disease, mainly there is regional where the basal posterolateral segment is affected most, because indicated by the lowest GLS, which is the site of maximum fibrosis. Here is a story of amyloidosis. What you will get in the echocardiography usually, increased left and the right ventricular wall thickness, thickened cardiac valves and atrial walls, the restrictive type of diastolic filling, dilated and the non-collapsing IVC, and the distinctive speckled appearance of the myocardium with a good systolic function. There is a good system, but there is a distinctive speckled appearance of the myocardium. You can see all the views, you can find the distinctive speckled appearance. This is very classical of amyloidosis. You can see even in all views, and when there is no intercavitary gradient, and when you divide in the diastolic function, the E by A is near about 3, and the E prime is almost 3, and the E by E prime ratio is more than 30. And there is a dilated inferior, what we showed you, there is the dilated inferior ventricle with non-collapsing. And you can see is the total, absolutely total mid and basal area GLS is gone, but only preserving in the APS, what we called it cherry on the top. Though it's not a specific thing, but still it's important finding in amyloidosis. If you take the ratio from the basal to the apex, it's more than 5:1, rather than more than 2:1. So it is a very important case of amyloidosis. Now coming from the hypertrophy and the valvular disease, next is one of the most burning areas is the CTR-CD, that is the cancer therapeutics related cardiac dysfunction. It really is a headache for us. Then you know GLS detects early subclinical myocardial dysfunction before the LVA. So any reduction more than 15% from the baseline, if you have the baseline, then identify subclinical LV dysfunction. So what we need in a case of chemotherapy patient is that GLS should be evaluated before treatment as a baseline, periodic monitoring throughout the treatment, and after completion of treatment. Because for early detection of cancer-related chemotherapy, cardiac dysfunction, GLS can predict cardiac toxicity much earlier than LVA. And incidence of heart failure and death increase by 6 times when GLS is less than 17.5% with normal LVA. So it is a very, very important. If GLS is reduced by more than 15%, suppose you don't have the basal one during chemotherapy, is regarded as the evidence of cardiotoxicity, where the beta blockers are supposed to protect the CTR-CD in patients with a significant reduction of GLS during treatment. I'll give a story of a particular lady, 42-year-old lady, known case of breast cancer, received post-cooperative chemotherapy, sent for evaluation for cardiac status. You see the ejection fraction is fairly maintained in this lady. And you can see the contractility is fairly well, near about 55 to 56%. So it's not that much of reduced, even all the views you can see. But when you do the GLS, you can see it is 14 minus 14, that is below 15%. That means patient developed cancer treatment related cardiac toxicity. So what we did, we stopped the chemotherapy as postponed in this patient. So started the beta blocker for 2 months, and the patient given the next cycle of chemotherapy and the re-evaluated by echocardiography. Here you see the contractility is much better, and contractility a little better, and all the views, and you can see now is the GLS is near about 21%. So we salvage the myocardium by doing the GLS. Suppose with the EF we have taken the patient to the chemotherapy, another course of chemotherapy, we have lost this patient, or rather we have to, she has to live with the cardiac failure throughout her life. Not only the cancer chemotherapy, subclinical cardiac involvement in systemic disease, particularly in the diabetes, there is a role of GLS. See, in diabetes, there is the increased torsion because of the presence of subclinical microvascular disease. Whereas in the Cushing disease, impaired LV longitudinal and circumferential shortening. I'll give an example of an uncontrolled diabetes mellitus. This is a 50-year-old lady, non-hypertensive. Remember, this is non-hypertensive, bilateral edema feet. Our blood sugar is a very bad control. But see, the echocardiography is fairly well, doing good contractility. You can see the contractility is fairly well. In all the views you can see fairly well, and GLS is minus 14.7. So even in uncontrolled diabetes mellitus, without any history of hypertension, can develop the subclinical myocardial dysfunction. Another reason is the heart failure with the preserved ejection fraction. See, GLS predicted mortality, but not the LVF, even if average, if the EF is around 40% or above. So GLS is found to be less in HFpEF patient, mainly with uncontrolled DM, hypertension and dyslipidemia. GLS is regarded the most robust ecoparameter for heart failure and the major cardiovascular event in the HFpEF patient. Hence, GLS should be done in all patients who are prone to develop the overt heart failure by identifying subclinical myocardial dysfunction. In fact, it has been recommended by ASD guidelines on heart failure. I'll give an example. This is a 49-year-old lady with a morbid obesity presented with the shortness of breath, decreased exercise, fatigue, chest discomfort, swelling of extremities, and you can see this is a biatrial enlargement. L is hugely enlarged, but contractility is LV is fairly well, and you can see the absolutely restrictive type of diastolic filling with the E by A is 3.4 and E prime is near about 5, so it's near about 25. E by E prime is 25, so it's a restrictive, and the pulmonary artery pressure is near about 45 to 48, and you can see the GLS, you can see the only minus 16.3%, and mainly is studied from the basal part is going to the apex. Is one of the features of any restrictive cardiomyopathy, not only the amyloidosis. So it's basically this patient is having heart failure with a preserved ejection fraction. But remember, the all biatrial enlargement is not the same. If you see the similar type of case of biatrial enlargement, you should not go into the Hartsman, this is a heart failure with preserved ejection fraction. You will have to look the 2D very carefully. You can see the small amount of effusion is there, and there is a lot of thickening around the pericardium here. And if you see, go more in that, you see the E by A ratio near is about 1.5. But here is the very important thing. You can see the tissue doubler velocity at the medial mitral malleolus is near about 10. But when you go to the lateral mitral velocity, it is 5. Normally what happens, the lateral annulus velocity is much more than, at least more for the medial mitral velocity. If it is less than that, that means it will call annulus reversus or paradoxus. This is one of the important features of constrictive pericarditis. Another feature is that due to the mitral inflow velocity, there is a more than 50% variation in the mitral inflow velocity, and there is a dilated inferior vena cava. And if you do the strain in this patient, there is a good LV function, and strain in this patient, what happens? The strain is preserved in near about 22.7% or 23%. And that happens in constrictive pericarditis. And by the way, you can differentiate very easily from the constrictive pericarditis. I told you in the previous slide, anything outside from the heart, the GLS is not reduced. Now come to the ischemic heart disease. There is a significant lower GLS is found in the angina. In acute MI, LV infarct size and the peak cardiac troponin T level correlate well with the GLS. Another important is that after reperfusion, GLS can predict LV remodeling, heart failure, extent of scar, even death. And GLS can provide better than RWA in the evaluation of significant CAD and increased incidence of reinfarction, CCF, stroke, and the increased risk of death than LVA. And GLS can also predict the effectiveness of the reperfusion therapy. And not only that, it can identify the myocardial segment which will improve after revascularization. For that, I have to give another important concept. Is called novel parameter called mechanical dispersion. What is that? It is used to evaluate the heterogeneity of the myocardial contraction and the chance of ventricular arrhythmia. And it is derived from the, how it is derived? It is derived from the standard deviation of the time to peak strain of all the 18 segments of the ventricle. And the regional dysynchrony is maximum with the longest mechanical dispersion. Hence, the GLS is considered an excellent predictor of morbidity and mortality in every patient of ischemic cardiomyopathy. How it is done? Suppose these are the patient. You can see this normal person. If you do the GLS, you'll find these mechanical dispersion is only 22 milliseconds. That is well within the normal limit. That means there is no dysynchrony. Here is the patient with anterior wall myocardial infarction. Is a lot of LV remodeling, LV is dilated, and there's a lot of rail remodeling. And if you do this GLS in this patient, you can see the PSD is 91 milliseconds. Anything beyond 75 milligrism, these are the patient more prone to develop heart failure, the more prone to develop the arrhythmia and the ventricular tachycardia. And that is not happening in the ischemic cardiomyopathy, also in hypertrophy. If it is a case of hypertrophic, is a case of hypertrophic cardiomyopathy. Here is you can see the strain. It is the minus 6%, but if you see the PSD is 102 milliseconds. So there is a lot of disarray in this there, and a lot of dispersion in the mechanical dispersion is there. So these patients are more prone to develop the ventricular arrhythmia. So I'll give an example of some two ischemic heart disease where you can even find out there is a doubtful segmental RWMA, but you can GLS will give you the good gains by your bullseye phenomenon. 50-year-old lady presented with the chest pain and suggestive of acute coronary syndrome. You can see these are from this patient, hardly you can find out any regional abnormality. Here in this view also, RWMA is not clearly seen, and even in the two chamber, there is some suspicion that inferior wall may be hypokinetic, but not. But if you go to the parasternal long axis view, you can see the posterior wall is definitely hypokinetic. So we did the GLS in this patient. So even from the short axis view, it's not very conclusive. But if you see the GLS in this patient, I'll make the bullseye mark. See the inferior posterior wall is definitely compromised. With overall GLS is minus 13.7. Similarly, another patient is the 42-year male present with the chest pain suggestive of acute coronary syndrome. Here is some suspicion is that maybe the hypokinetic apical anterior wall is there. Here is also from the fourth chamber, it could be hypokinetic, but not 100% sure, particularly to a novice. Here is also is not very discernible, but if you do the GLS in this patient, you can see the anteroseptal area is definitely compromised with overall reduction of the GLS is minus 14.6%. Even in the triple vessel disease, the 57-year-old man present with the angina and positive TMT, heavy smoker, good systolic function. But if you do the GLS in this patient, you will find the GLS is near about 16.4% with definite evidence of ischemic heart disease. Now I'll give you how the parametric image, the bullseye, give you a very important idea of the echocardiography. It's a thinned out and dyskinetic LV apex. You can see very easily from the 2D, the thinned out and dyskinetic LV apex. But how is there's absolutely dyskinetic LV apex. And if you see the bullseye phenomena, you see the apical part is strain is almost 0, is a 1. So this is absolutely a scar. And other areas, these are the areas, anteroseptal areas is hypokinetic and otherwise fairly well. So these concludes the ischemic heart disease. Another area is the transplanted heart. See, this is the patient with the transplanted heart. You can see the atrium is anastomosis with the pulmonary veins anastomosis here. This is the recipient. This is the recipient atrium, and this is the donor's atrium that is sutured here. And you can see the contractility is fairly well, and here is also the contractility is fairly well. And if you find that GLS is minus 17.2, which is transplanted patient is regarded as almost normal. Why? Because if you give this data that anything less than 14% is of orisum, because there may be chance of rejection. Anything more than 16% is fairly doing well. So in this case, 70% is fairly doing well. Another area is a very, very important area, not came in the recommendation, but this is a 2020 articles where in the COVID-19 cardiac injury, implication for long-term surveillance and outcome in survivor. So there are a lot of patients in the COVID area. We are doing echocardiography in a HEST, not the full echocardiography, where you can see the cardiac function well. But when this patient was discharged in a stable condition, they come outside. Sometimes they complain of dyspnea or exertion or fatigue or defatigability. These are the two patients. I'll give an example of two patients. What happens? See, this is a 42-year-old lady. She was discharged in a stable condition after a stormy area in the ICU, and we have done the echocardiography. Is absolutely normal. You can see this is absolutely normal, but she is complaining of dyspnea and exertion. But if you do the GLS in this patient, is seeing 22.8%. So we can tell there is no subclinical myocarditis or subclinical myocardial dysfunction present in this case. On the contrary, the next case is a 38-year-old gentleman, similar history. After 1 month stay in the hospital, he was discharged. He come after fall-off for after 1 month, complaining of something fatigue, dyspnea on exertion, easy fatigability, tiredness, and we did the GLS in this patient. The conductility is fairly well, and we did the GLS. The GLS is here is minus 17.8%. So these are the group of patient needs some more careful observation, because we have listening that these are subclinical myocarditis may persist longer time and prone to develop ventricular arrhythmia and the sudden death. So these are the areas to be explored. I am giving a glimpse of this. So what is the recommendation in the 2000 team? That in convalescent phase, in the 2 to 6 months, you do the ECG and echo, cardiac monitoring of the symptoms, consider patient-specific cardiac risk factor if it is abnormal. Even if it is normal, the patient is symptomatic. Consider advanced imaging like echo with strain or the LG MRI scan with the late gadolinium instrument to find out any early abnormality. Now, this completes your LP. This not only RV dysfunction is also can be calculated subclinical dysfunction. There is a 30-year-old lady present with the peripheral edema, anorexia, nausea, abdominal pain, hepatomegaly, fatigue, and dyspnea. This is a good LV. There's nothing to see. Good evening. But see, the RV is not that moving normally. RV is enlarged also, and if you take this, there is a grade 1 tear only, and if you measure the pulmonary artery pressure, it is coming down near about 75 to 80. The severe pulmonary is a known case of primary pulmonary arterial hypertension. And if you see, the RV GLS is reduced minus 15.2. And more so, if you take the RV free wall GLS, only in this 3 segment is minus 12. It should be more than 26 to 27%. So these are the patient of pulmonary arterial hypertension developing early subclinical myocardial dysfunction in the RV. So it needs really attention. Not only this, LA, whether there is any role of LA strain in the subclinical myocardial dysfunction? Yes. Peak atrial longitudinal strain PALS or LVGLS, both are reduced before developing over CTR-CD. That means in cancer chemotherapy. PALS decline showed better sensitivity and specificity in predicting future CTR-CD than LVGLS decline. And it has been recommended. Serial measurement of PALS can be used as a useful parameter for the prediction of the future CTR-CD. So here is a patient, you can see the good LV function. LV function is fairly well, but if you see that LA volumes in this case, this is the maximum volumes, this is the minimum volumes, and this is the pre-LA volumes. All are mildly increased, not much. But if you take all the volumetric function, you see the reservoir function is mildly reduced, conduct function is also moderately reduced, and contractile function is also moderately reduced, with the total empty function is also moderately reduced. But these are certain parameters are also within the normal range. So we are not sure what is happening. But if you take the peak LS strain is only minus 18%. That should be more than 25 to 26% in normal person. So to summarize my presentation, strain measures myocardial deformation. Most common clinical application is the GLS of LV. Normal GLS is more than 20%. There is a fastidious attention to detail and the learning curve. Summary 2 is simplified clinical application. One is the pattern recognition by the bullseye plot that I have shown you the plenty of examples. Another is the subclinical dysfunction that has also been detected by many of the cases. And next upcoming is the regional variation by the strain curve shape, which I will give you a glimpse of that. So past is past. Now what we can do, we can evaluate the LVH in heart failure, cardiotoxicity, aortic stenosis, and ischemic heart disease. And the future, which I have given a glimpse of it, is the diastolic function, residual variation, RV strain, and the LS strain. To summarize in a single word, speckle tracking is a mathematical technique for tracking and evaluating the movement of the myocardium throughout the cardiac cycle. So it can be used in numerous applications to mathematically represent systolic function in any subclinical myocardial dysfunction. So these are the reference. Thank you.
Right. Thank you so much, sir. And dear viewers, we encourage you to post your questions in the text box. And sir, while we wait for questions from the viewers, there are a couple of topics I thought might be worth actually revisiting from your presentation itself. So I thought that the requirements for strain imaging and the caveats, that might be an area worth revisiting once more.
Okay, so I'll go that way, yeah. First, you want the caveats.
Absolutely, sir. Yes.
Because the caveats is a very, very important area. So that is very, very important area. Cavity is a very, very important area. So then you go cavit. Just a minute. These are the areas. So caveat 1, that is the variability. That is the inter-vendor differences. So what should be done? Because you can see in the GLS, so there is a certain thing, some code is now being prepared and already being prepared to find out the opinion of the inter-vendor variability, to circumvent the inter-vendor variability, but it's not really in usual practice in India at the moment. In the USA, they are trying to solve it by the ACVI and the ACE guidelines. But here is the important is that this cavity is the most important. You should, you can do any machines on any vendors, that is not a problem. But a particular patient where the, if you want to do the GLS very accurately, that the serial assessment of GLS in individual patient, particularly in the cancer chemotherapy, valvular heart disease, particularly where even the 10%, 15% difference is very, very important. You should perform using the same vendor equipment and the same software. So that is the caveat number 1. Second thing is the same in the normal values. That has more or less, but by the time it's standardized, particularly in the LV GLS is 20%. So if you remember the 20%, anything more than 20% should be regarded as a normal. Anything less than 20% is abnormal. Particularly in the cancer chemotherapy, if you have a baseline value, then you reduction the 15%. 15% reduction is considered as a toxic. And caveat 3 is the most important, is that you have to have a very good 2D image. Otherwise, if you do the strain, your values are bound to be erroneous. So this is the 4th. And last 4th is that you have to have certain amount of training to learn the curve. At least individually do the 50 cases and show it to your seniors to find out whether you are right or not, and then you will be able to find out that you are perfect. So that is another area of caveat.
Right, sir. Thank you so much. And there was one more concept that you covered, a fairly new one. If you could also cover that again for the viewers on mechanical dispersion, sir.
Yeah, that is the new area that I am telling you. Before that, just probably here is there. No, just yeah. This is this mechanical dispersion is very, very important in particularly ischemic heart disease, and also in hypertrophied heart, and also in any case of amyloidosis where there is a lot of dyssynchrony and a lot of dispersions of the of your strain values. That's why it's called mechanical dispersion, is used to evaluate the heterogeneity of the myocardial contraction. The one particular segment is going this side, other segment is going up, and other going down. Particularly, you'll find the desynchrony. And these are the patients who are having the mechanical dispersion more than 75 milliseconds. You will find these are the patients who are prone to develop ventricular arrhythmia and the cardiac failure most. It is derived from how it is derived? It is only derived, that is the time to peak strain of each individual segment. When you do the GLS in the bullseye map, you can see the time to peak strain in each segment. And machine calculate the standard deviation of all 80 segment, and they will give you the mechanical dispersion. And this visual dispersion is maximum with the longest mechanical dispersion. See, this is a normal one. So if the normal one you can do it, the mechanical dispersion is only 22 milliseconds. That means there is no mechanical dispersion in fact. Because here GLS is near about 21. So there is no mechanical dispersion. And all are going the same way. But here you can this is a anterior wall infarction. If you see this, even the mechanical dispersion is less in an infarcted patient if it is not LV is not remodeling much, where the work index is not lost properly. But if there's a lot of remodeling, there is an interesting paper came in the 2020. You can see the work index is maximum lost when there is a LV remodeling. For the lack of time, I'm not able to include this work index also, and that will be interesting one with the mechanical dispersion. But here you see because of the lot of remodeling, is the mechanical dispersion is more than 91 milliseconds. And even in the hypertrophic cardiomyopathy, where there is a lot of D-series, myocardial D-series is there. So you can see these in the patient, in this patient is the mechanical. The GLS is only minus 6.6, but the mechanical dispersion is 120. That means time to peak ratio, if you do standard deviation, suppose one is 22, so another is 200, another is 500. So if you do the standard deviation of that, is coming to 102 milliseconds. So that's why this is the mechanical dispersion. So this can be easily calculated when do you use the GLS. The machine can automatically give.
Thank you, sir. Thanks so much. And there was one final request. One of your last slides, sir, actually, the flow chart that we could follow in case of
in the COVID area.
Patients. Yes.
COVID, okay. And that is a very important. This came in the 2020. This is the last chart I have given. Oh, really? This is that. So if you carefully take it, see, this is this side, this is an acute one. When there is your suspected myocarditis, when in the COVID ICU or in the COVID ward, where you do the measure troponin, the measure BNP, if it is elevated, then probably it is STEMI. If it is you do the first and the ECG and the normal basic echo. If you don't have the facility of doing the strain imaging, then cardiac monitoring depending on the symptoms, then consider patient-specific cardiac risk factors. The other risk factors like diabetes, dyslipidemia, whatever is there, obesity, that has to be corrected. If it is abnormal, if any of these abnormal things is there, or the patient is symptomatic, or better if you want to be sure, at least do echo with strain. If it's not the LG with the MRI scan. But if you do the echo with the strain, and if you find the strain is low, you must do the LG with MRI scan. The treat is then clinically indicated. So that is the most important area, probably upcoming. So this is the recommendation they are giving. This is the conclusion in the study after that. This is the recommendation they give. This is still not standardized, but this is an upcoming subject. Nobody knows what will happen after 1 or 2 years. Nobody knows what is the long-term sequelae, because COVID is only 1 year old. And still is going on, and after and nowadays, see, lakhs and lakhs people will be affected, and after 1 or 2 years you will find that huge number of patients you have to deal with. We do not know, but most concern is the initial 2 to 3 months, where we are now getting a lot of persons, including a few days back one doctor died, the doctor in the Echocardiography Medical College. He was discharged from the hospital, and then he is a famous neurosurgeon, and then he was then took rest for 15 days and joined his professional duty, and suddenly he died due to probably the cardiac arrhythmia, because he could not get any time for treatment. So there's some very unfortunate things are happening, and people are finding out the ways how can you find these high risk patients, particularly those are not having much symptoms. So these are the areas really has to explore. I think this is the area is a challenging ahead of task in the next 1 or 2 years.
Right, sir. Thank you so much for that. I think that's an interesting story. And we will just take one final query from the Q&A, sir. So we have a question, which is your personal take on bullseye plot versus graphs. So which do you prefer and why?
See, here one thing I must say. So bullseye give you a absolute initial impression. First initial impression. See, when you see the bullseye, you will find that these are probably I am dealing with this type of patients. See, suppose there is the apical sharing, so it could be amyloidosis. So we'll go again ultimately the strain curves. But strain curves are very important is ischemic heart disease, where the bullseye may not be so helpful. But if you go to the particular individual segment of strain, where you are finding that could be these are the areas of culprit vessels may be affecting this particular part of the myocardium, with the strain values of particular segment is most important. But in a certain situation, the bullseye will give you the tricks. But strain values are of course, but it has not been standardized the regional strain values, which should be how much is you should regard as the normal and how much abnormal. Global longitudinal strain, global is now standardized. But regional strain, longitudinal strain rather, is not still yet standardized. So that's why you can go with that. But overall, first impression is that you have to have the average global longitudinal strain. If it is less than 20%, then I first look at the bullseye, and then if you are not sure from the bullseye that what are the particular segment is going maximum affected. Because see, in certain strain, I told you the Fabry's disease. See, if there are a lot of patients of amyloidosis and Fabry disease, it looks similar in the echocardiography. You may not be able to differentiate it. But if you look at the posterior inferior segment are much affected particularly, then if you give a clinched diagnosis that could be Fabry's disease, and then you can go ahead with the cardiac biopsy. So these are the areas.
All right, sir. Thank you so much. And with that, so we come to the end of a wonderful session. A very special thanks to you, sir. This was a very important topic, also very informative. And I personally really enjoyed the way you presented some of the points, such as the strain imaging caveats, the clinical applications simplified, and the cases also so lucidly explained. I think it was really a good fortune for us that you shared these with us. Thank you so much for that, sir, and looking forward to many more wonderful sessions with you, many more learning opportunities in future. And I'll just come back in a minute, sir. So, dear delegates, we truly hope that you have enjoyed this session. We hope that this benefits your practice. Thank you so much for all the encouragement and few closing remarks. So once the video feed terminates, the feedback form will pop up automatically. We encourage you to record your feedback in this. We look forward to your response. look forward to also meeting you in our future sessions. We have one coming up next week itself. So do stay tuned for that, and you'll hear more about these from our team. Special thanks to the technical team for the hard work behind the scenes keeping the feed up and running. Thank you. Look forward to your feedback. And one final time, Dr. Aniruddh, sir, thank you so much for the knowledge that you have shared with us today. It was wonderful.
Thank you, everybody. Thank you. Thank you, everybody.
Right, sir. Thank you so much.
The meeting has ended.